we are.
Should I start?
Sure. People will trickle in, but you guys can start your discussion and spiels.
Okay. Well, then I will kick it off. Thank you, everybody, for joining us this morning. As you can see, it is a bright and sunny day in Chicago, and I have the pleasure to be moderating this session for Global Radiology Opportunities. And we have a fantastic lineup of speakers here. I'll start by introducing myself. I'm Susan Palassis. I'm originally from Greece, and I came here as an international medical graduate and followed the challenging route of making my way to the United States. Currently, I'm the division chief at Lurie Children's and professor of radiology at Northwestern University. And I had an international experience myself, well, just going back to Greece, obviously, but also I had the honor of being an invited professor to Black Line Hospital in Ethiopia, and that was really a fantastic, such a rewarding experience. So we have our wonderful panelists here. They're going to share their experiences in regards to these, global international opportunities that are available to you all as trainees. And I think it's great, that radiology is, we're realizing the real value of radiology, in these outreach programs, important for, preventing death. And, it's such a critical piece of the diagnosis and making it available to these, low and middle income countries. So I will start with Dr. Mitchell Farag, who is a diagnostic and IR radiologist in private practice in Morris, Illinois. He's been very involved in RadAid, and so you're going to learn a lot about this wonderful program. And as a fourth-year resident at Loyola, developed a PAC system for a small hospital in Nairobi. So Mitchell, if you want to take it away, we'll start off with you.
Great. Thanks a lot, Susan. I appreciate the introduction. I'm going to go ahead and share my screen here. All right. So as Susan said, I'm now in my first going on second year of private practice here. I'm in a small practice in Morris, Illinois. I did my residency at Loyola. And I'm going to talk to you guys today about RadAid, something that when I discovered kind of early on in residency and even as before that as a medical student, it invigorated me, and I would say definitely fueled my passion for radiology. And I would even say changed my life for the better. So I'm really excited to talk to you guys about that today and offer as much info and insight about RadAid as I possibly can. I'm also going to go into some details about a project that I was involved in back in 2018 when I was a fourth-year resident, as Susan was saying, with the overall goal of PACS implementation in a small hospital in Nairobi. So with that, I think it's important to start out with exemplifying how important radiology is on a global scale. As you guys know, it's a huge cornerstone for any hospital. Every single department in the hospital utilizes radiology. And so I just want you to imagine a hospital now without a radiology department, and how that would affect and have a clear domino effect on every single other department in the hospital. And that's without exaggeration. So imaging really extends to every single field of medicine. And on a global scale, this ends up causing significant health disparities all over the world. It's estimated that over half of the world lacks a functional radiology department. So radiology is a portion of medicine that I think is really underappreciated in terms of its contribution to global health disparity. And so that's where RadAid comes in. RadAid is a wonderful non-for-profit organization. It's relatively new. It was established 2008 at Johns Hopkins by a small group of volunteers. And the overall mission is to improve and increase radiology in low and middle income countries, as well as in impoverished areas of higher income countries. And the goal is to bring radiology to these underserved regions by means of infrastructure, equipment, education. And as I'll talk to you about a little bit more, the main focus of Rad Aid is in establishing a system that can be self-sufficient and functional on its own without reliance on volunteers to continuously go and nourish the system. So the goal is to create independent, self-sufficient systems all over the world so that they can establish a cycle of education and improvement and not be volunteer dependent. And so I think that's one of the main things that attracted me to Rad Aid when I first discovered it. There's over 14,000 volunteers. They're involved in 38 plus countries. I'll show you a map in a little bit, and in over 85 hospitals in those countries, and it's continuing to expand. So it's really a wonderful program. The way Rad Aid works is they have a clear and established cycle. All right, so it starts kind of with the cornerstone, which is a radiology readiness assessment, which is essentially a broad context survey of an institution's current and expected future capabilities to deliver radiological infrastructure and needs to the surrounding community. So the assessment takes into account the demographics of the surrounding community. It asks questions about what kind of population is here? What are the current needs? What are the screening needs? What are the preventative medicine needs? It asks questions about the hospital infrastructure, hospital staffing, resource availability. It's really a deep diving, detailed survey into a hospital's current radiology system and infrastructure if they don't have any radiology in place. So even bare bones, starting from scratch, it's essentially a question asking, how equipped is this hospital right now to support radiology? So, let's say in the hospital with a really high prenatal population, large focus would be on delivering ultrasound and accessible ultrasound. High breast cancer population, a lot of the focus would be on mobile trucks and screening mammograms, et cetera. So that's it's really a neat kind of focused way to delve into a community's needs. The nicest thing about a radiology readiness assessment is that you can do it. It's easy. All you have to do is just take the initiative, ask questions. Even right now in a post-pandemic world, it can be done remotely if you establish a contact there by asking a series of questions. And that's the first step in setting up a radiology program. So anyone who's interested enough, even starting from scratch, can go ahead and conduct a radiology readiness assessment on their own for a country inside of their choosing, which I think is really wonderful. So the next step is, of course, planning. So there's an outline and plan in place in terms of how the implementation process is going to go about. And that takes into account hardware installation, software installation, what types of PACS system that they would best be able to support. There's PACS light systems, so to speak, for more underdeveloped areas. And if let's say the internet speed is high enough, then it can maybe support a more robust PACS system as opposed to starting a little bit lower. It takes into account things like technologist training. Are there technologists on site? Are there people who can be trained as technologists, et cetera, things like that in terms of the overarching inner workings of the department. So that's all planned and outlined. And after that, the implementation process starts. And that essentially goes off the outline and the radiology readiness assessment in terms of actually getting these wheels in motion and getting all these things in place to get the bare bones working. And arguably the most important part is in red on the bottom left, training. So this is, like I said, the cornerstone of Rad Aid. It's actually imparting education as opposed to just, setting up hardware and software and saying, all right, good luck, we'll be back next year. That's not going to work. There's no point setting up a system if they can't be self-sufficient. So training and education, offering what we've been privileged enough to receive in the West, we can offer to them and offer our expertise in order to get someone there on site who's able to train future generations and anyone else who might become interested and involved. And that doesn't just happen on the radiologist level, that happens on the technologist level, on the business administration level, especially on the IT level. In all those reigns, it's extremely important to facilitate training for the goal of self-sufficiency ultimately. And then after that, we take a look at what gaps are there, what can be improved. You analyze how the current system is doing, and come up with strategic ways to improve that system and make any flaws better, or say, you know what, this worked, let's keep this going. This is not working as well. Let's see how we can improve this. Let's see who we need to bring in to make it better. And after that, it actually continues. So a repeat radiology readiness assessment is done to reassess, this program, is it succeeding or is it failing? And if the latter, then what can we do to improve it? Do we need to start from scratch, or which gaps do we need to fill in? So it's a continuous cycle. And I think that's the genius of Rad-Aid, is it's not just like a 3-step plan. It's an ongoing persistent cycle year after year, in terms of making sure what you've set up is self-sufficient. So where is Rad-Aid involved? All of these locations, at least. This is probably a couple of years old. So like I said, over 38 countries are involved in Rad-Aid or have some sort of Rad-Aid protocol in place in most continents. So honestly, as a volunteer, you can just pick a site that you want to get involved in, and there's an easy route set up to find a contact in that site and reach out to them and get involved. Or you can pick a new site. Dan Malura, the head of Rad-Aid, is very, very open-minded, and it was very easy for me to say, hey, I had a hospital that I was aware of in Nairobi that had nothing in place, and I offered it up and I drew up a plan, and he said, yeah, let's start a new site there. So it's so easy to establish a new site or a new country, something that's near and dear to you. So in terms of volunteering, obviously right now things are a little bit tricky. Given the pandemic, right now volunteer activity is suspended for safety reasons, but Rad-Aid is still very much at work via remote education and infrastructure development, teleconsults. There's all kinds of ways of staying involved despite the lack of travel right now. So hopefully in the future, hopefully in the near future, we'll be able to travel again. But until then, you can look at it as an opportunity to pinpoint something that you like and start developing it remotely. And then once we're able to travel again safely, you may be able to hit the ground running. So there's a volunteer registration form on the website. Here's the URL, but it's really easy. You just go to rad-aid.org, and there's a volunteering tab. Just go through that, and it takes you right to a survey. You submit the survey and you're registered. It's that easy. There's an annual conference in November that's actually taking place right now, today and tomorrow. It happens early November every single year. So as you can see, Rad-Aid is still, it's definitely not hit the brakes. Everything's still very much up and running. There's, I think this year, over 350 attendees. I attended it a couple years ago, and I was able to get my project mentioned in the conference as something currently and early on in development. So it was really wonderful to have that small little hospital on the international map for everyone who's attending. So that was really nice to see. So in terms of that hospital, I'll talk to you a little bit about what my mission was when I went there. This is a hospital that I discovered a few years ago through my church that I'm involved in. I went to this hospital in the early 2010s and volunteered there, did some work there. And that was when I was, early on in training and interested in radiology, but couldn't help out in radiology since I wasn't trained. So I decided to start looking into it at that point. And when I found out about Rad-Aid, I figured that was a good opportunity to try to implement something in terms of giving them a digital radiology system, because I would go there and I would see them carrying around films in brown envelopes from building to building, just so the radiologist could hang it up on the screen and look at it. So I figured, why not try to get them started with something digital? So I did a site visit, and prior to going on site, I completed a radiology readiness assessment. So I filled out everything and I sent it to Rad-Aid. And then the next step was kind of go there on site and get some more details to complete the survey and make sure everything's accurate. So it's a 250 bed hospital. And the goal was basically to just see how the department's laid out and see what modalities they have and what they're capable of and what they aren't capable of, compare it to that readiness survey I did a couple of years prior. So I spoke to the IT guy there and got the numbers for, internet and network strength and power supply. And he showed me the things that I wasn't, too informed on, like the utility closet. And I got to learn a lot about, in general, how a PAC system is set up and how digital radiology would be set up. So I got a lot of insight in terms of what the general needs of any radiology department are in terms of the deepest infrastructure. So I spoke to the techs and I got the numbers in terms of how many of each modality they perform each year and what machines they have. I found out that surprisingly, everything was actually DICOM enabled, except for the mammo machine. They had 2 X-ray machines, fluoro machine, and 3 ultrasound machines, one of which was portable. They had a 128 slice CT scanner and an old MRI, which unfortunately was not working. So they needed some work, but they actually had a bigger foundation than I had thought initially. So that was impressive, and that was nice to see. I got the numbers and kind of delved deep into their paperwork, and I sat down and analyzed it, and I saw that they were doing about 30 X-rays per day, 7 CTs per day, about 15 to 20 ultrasounds, on average 0 to 1 fluoro study, and 1 mammogram every couple days. So pretty nice numbers for someone in private practice, but for a small hospital like this with 1 on-site radiologist, it can be a little demanding, given all the extra work from the phone calls and all the other questions that you have to take. That's about close to 60 studies per day, but she's not reading them digitally. She's reading them kind of the old archaic way. So that adds a lot of time to the day. So she was actually pretty busy. Like I said, 1 radiologist, she was working from 8 to 5 documented hours, but she was actually working a lot longer than that. And they were alternating covering radiologists on site from Kenyatta Hospital, which is a bigger hospital nearby, as well as Aga Khan. They had 5 total techs for all modalities. So about 1 tech per modality. Notice there's no ultrasound tech. The radiologist was looking at them on the screen and just kind of reading them as they go. And she was performing them as well, needless to say. So she was doing them, interpreting them on the spot. And then there were a couple portable ultrasounds as well, which you would have to go up to bedside and do. So you can only imagine. The current department layout, they had films, like I said, for radiography and mammo, and the ultrasounds were viewed on the machine. The CT images, actually, it was nice because the CT scanner came with this very archaic software that actually allowed you to view it on a screen, but with very minimal post-processing ability. I mean, their recons weren't very good. Obviously, they're not doing advanced things like MIP, and they're they have zoom and measuring sticks, but that's about it. I got to see this for myself and kind of play around with it. It's pretty archaic, but I was surprised that they at least had some sort of digital form of CT, so they didn't have to look at it, on the screen slice by slice like the old school way. They were in between electronic medical records. They've been through 3 to 4 in the past 10 years. Obviously, Epic is not even a discussion here. They can't afford things like that, and there's no donation from big companies like this. They're not willing to really give the time of day. I mean, Epic's wonderful. I don't blame them, but they're not willing to give the time of day to a really small hospital like this. So they're using a bunch of EMRs, and a lot of them had very much very different problems and very significant problems. So they couldn't really settle on one. When I was there, they had one that had been in place for about a year or so. They were just starting to use MRNs for patient tracking. So this is a really early medical system. They had no RIS or radiology informatics system for scheduling and protocoling and things like that. And we did things like inspect the inner workings of the department from an electronical infrastructure standpoint. And Red Aid had given me discrete instructions from their expertise, from their IT experts. So I wasn't expected to bring IT expertise. I'm just kind of the messenger. But they gave me a list of things to look for. For example, things that you would never really think of when you're walking around the inside of radiology department. Like, for example, a thermostat or an alarm when the thermometer, when the temperature goes to a certain height inside the room. they needed some form of alarm to say, hey, this is getting too hot. That's a clear safety hazard, right? So that was one thing on the spot. I worked with the IT guy there to order an alarm and set one up. Just one of the basic things that you never really think about, but that's absolutely necessary for when you're storing all these digital files. So the volume of studies were increasing, and we started to see significant improvement. They moved to about 400 plus X-rays, 300 plus CTs, and 100 plus ultrasounds in 2017 compared to the year before. So they're really expanding, and this is all, you know, just kind of from our encouragement and our being on site and letting them know, hey, here's what you can do to improve what you're currently doing. The internet connection speed even increased by a meager 5 to 10 millibytes per second, but that was significant for them. And they're still planning on improving it, you know, up to the next goal is 25, 50, and then eventually higher, things like 100 that would be able to support a really robust PAC system. They're planning on adding a 1.5 Tesla MRI to replace their broken MR so they can start doing MR. And given that, they're, you know, you can see kind of on the right, the rubble here is a new building that they're clearing out so that they can put the MRI on the first floor. So they're really planning on, you know, they were set. The COO of the hospital was really set on let's make radiology big here, and let's get a good program in place because this is such a central component to the hospital. So just being on site, I really saw that there was improvement there, and you know, I essentially gathered the numbers and upgraded the radiology readiness assessment. We were planning another informatics site within a year, which that was kind of bordering on when the pandemic was starting. That informatics site visit happened, and we had other people on site. I was unable to go just due to my training and vacation time and things like that. But we had someone on site, and they developed a kind of a PACS Lite program there, something that can be improved on in the future, but we essentially digitized radiology for them. So it was really wonderful to just kind of invigorate that, because once I started with them, they hadn't really, PACS wasn't even really on their mind. You know, I met with the COO in the hospital, and he's like, oh yeah, that's a good idea. That, you know, how much would that cost? Rad Aid just does it. They don't charge anything. This is a non-for-profit organization. So it was almost like, well, what's the catch? And then, you know, we took a look at things that they need to improve, like repair their X-ray and mammo machine, and certain radiography cassettes that had gone on the back burner that they hadn't really thought about replacing, that we just kind of brought to their attention. So, you know, it was really wonderful to see everything that they improved on and everything that they can improve on in the future, and to see this tangible difference being made was absolutely phenomenal. So hopefully once the pandemic clears out and we're able to go again, I plan on going once I'm able to reassess, maybe do another readiness assessment and see if anything can be improved on, see how their EMR is now, improve on that, see how the MRN protocol is, see if they can establish a risk, et cetera, things like that, get them functioning on a better level. So I don't know how much time I've taken up, but I feel like it's probably too much. So I'm gonna cut it off there, but thanks a lot for listening. I appreciate it. And get involved with Rad Aid. It's easy.
Thank you, Mitchell, so much. That was really nice, presentation, telling us your experience. I actually was really amazed. I did a little bit of research myself, and I found that for Rad Aid International, that there's a 50-fold increase in student and radiology trainee volunteers in the past decade, which is amazing. And also that to accommodate this growing interest, that the ACR has also developed a program called the Goldberg Reader Resident Grant.
Yep.
And they've received like up to 60 applications. So there are, resources out there if you're interested in expanding in this way. Anyways, thank you so much. In order to keep on time, next we're going to go to Dr. Koon Hong. It's my pleasure to introduce him. Dr. Hong is originally from Korea, went to medical school in Seoul, and he trained in Chicago at Mercy Hospital and Rush in diagnostic radiology and nuclear medicine. and he has been working at a mission hospital in Addis Ababa for the past 5 years. So Kuhn, take it away. We want to hear about your experience.
Hi, can you hear me?
Yes.
Okay. My name is Kyun Hong, a retired radiologist. I worked at the OSF Little Company of Mary Hospital in Evergreen Park for 34 years and had an opportunity of visiting many countries as a short-term medical mission. At the beginning, when we had no cell phone or internet, I called several organizations inquiring whether I could visit other countries as a volunteer. They were happy to pick up my phone call and ask what specialty I was. And I said radiology. They said, no, thank you. We don't need a radiologist. And therefore, I started as a primary care physician using the stethoscope at the mobile clinic setting with no electricity and no X-ray equipment. And I had an opportunity to visit many countries after that. And ultrasound was developed and the small portable units, Sonosite particularly introduced a few years later. And I was so happy to use the ultrasound as a diagnostic tool. Eventually, the CT scan was installed in many hospitals in America, and that also a third world country hospitals, including the university and mission hospital, start to install the CT. But not like America, they do not have a radiologist to work in that hospital, and the opportunity for me and other radiologists to visit those hospitals. And after 34 years of the practice, I decided to retire early. I went to Ethiopia to spend my 5 years at Myeongseong Christian Medical Center in Addis Ababa. And when I arrived there, I found out they have 5 Ethiopian radiologists already. They were scared that they're going to lose a job. And I assured that I just came here for help as an assistant, and I tried to calm them down. And then after working for several months, I decided to go for interventional radiology. However, after 30 years of practice, I have not done any interventional procedure since I was specializing in nuclear medicine, reading the nuclear medicine scans and general radiology stuff. Because of the privilege problem and the insurance issue, I could not do hands-on practice at our hospital before my retirement, except that I was able to enter the angio suite to observe some of the procedures. But I met a young Korean radiologist visiting the hospital, and he happened to be an IR specialist, and self-invited myself to go to the hospital in Korea. And since I graduated from the medical school in Korea, I had a valid medical license and speak fluent Korean, and the mature looking appearance certainly helped to do the procedure. And I stayed at the hospital for 3 months. And when I come back, I start to do the procedure from the basic. The first case I had, like a 38 years old lady who had an operation from the outside hospital in a remote area. On CT scan, you could see that there is a large abscess cavity in the abdomen, black and the gray collection, in comparison to the white bowel loops containing the oral contents material. Our surgeon refused to open up and refer to us. Under the ultrasound guidance, I was able to drain the pus collection and left the drainage catheter to clear up the lesion. The patient felt immediate relief of pain and the temperature went down the next day. Few days later, the patient walked out from the hospital. From that, I was able to drain a lot of fluid collection in the chest and abdomen and so forth. biopsy of the liver, thyroid, breast, the kidney, and so forth, and they did a lot of different procedures. However, not in like America, there are many hepatocellular carcinoma, HCC, in Korea as well as in Ethiopia. I wanted to learn transarterial chemoembolization of the tumor masses in the liver by angiographic procedure. While I was in Korea, I met many professors in specializing IR, and I invited them to come over to help us. I was able to recruit 10 Korean IR professors committed to come at least once a year to spend 1 week at a time. So we made arrangement that they come on Sunday, stayed until the next Saturday, and we start to do the interventional radiology fellowship program in Ethiopia. I was able to recruit 5 young Ethiopian radiologists for 2-year program, and I collected all the liver cancer patients and obtained the CT scan before the Korean radiologists arrive. And when they come, they start to do the procedure. This is Dr. Cho that I was trained under him for 3 months. And at the beginning, the visiting Korean radiologists were performing the procedure with Ethiopian radiologist assistant observe. Then we allowed Ethiopian trainees to perform the procedure under the strict supervision of Korean radiologists. And eventually, we allowed Ethiopian radiologists to start from the beginning and end the procedure, while the Korean visiting radiologists were staying outside of the angio suite unless the Ethiopian radiologists faced some difficulties in asking the questions. I covered the rest of the 3 weeks of the month, and the time flew quickly for 24 months. And they formulated Ethiopian Society of Interventional Radiology, and the 5 trainees became president, vice president, secretary, and treasurer, so forth. And while we had a first Ethiopian IR Society conference, I gave the presentation of the radiation safety issue to the meeting. And finally, they were able to finish the training of the 2 years and receive the certificate. And they became the pioneer of the IR in Ethiopia. And because I had a specialty training in nuclear medicine, I worked closely with Dr. Solomon Demera, professor of Black Lion Hospital in Addis Ababa University. We studied 3 years of nuclear medicine residency training program there. We recruited 10 young physicians, and they studied the residency, and I gave the lectures to them. But when they finished the first year training, only gamma camera in the whole country of Ethiopia broke down, and we had to make arrangements for them to go to Italy to have a clinical training instead. I hope in the near future, Ethiopia will be able to get not only the gamma cameras, but also PET scans, so these newly trained nuclear medicine specialists can practice their knowledge to help the patient. And while I was at the hospital, I gave the lectures to the Myeongsang medical students who attended the hospital. And I started from the first year of the anatomy class and eventually 3rd year medical students when they came to the radiology department for clinical rotation. Since I'm stuck in Chicago due to the COVID pandemic, I help by reading the cases by internet, teleradiology service. They covering the small mission hospitals around Africa. One is a Sodo Christian Hospital in remote Ethiopia. Another one is the Bingo Hospital in Cameroon and Kenweg Hospital in Kenya. The beauty is that you don't have to travel. You can read while you're at home wearing pajamas. And as soon as you read, critically injured or trauma case, the surgeon can bring the patient to the OR immediately. Or in another case, when you had a CT scan from the head to toe, the patient had a cancer from the liver, metastasis to the lungs and the brain, and we could assure the physician that they don't need any a heroic surgical procedure because the game is almost ended. So, and I have a hobby in painting. As a matter of fact, when I was graduating from high school, I wanted to go to the art school, but my parents would not allow me because the artists and musicians would not make a living in the developing country, particularly after the Korean War. So I went to medical school as a second choice, but I continued my interest in painting. I had a solo exhibition in Ethiopia, Korea, and France, and many of my pictures were featured in different magazines, including the Swedish Surgical Journal. And it was appeared in the Chicago Medical School, Synapse magazine. I would like to conclude my presentation by saying that there are a couple of the organizations you may be interested to learn. Because so many medical graduates have a hefty school loans, and you are not able to go to the foreign country to help those. But one is post-residency program from Samaritan Purse, www.Samaritan Purse organization. They will send you immediately after the residency training program. They support financially for 2 years. And if you like it, you could stay longer, or you could come back and just start to get a job in America. Another one is the medicine that they will pay your school loan while you are working overseas for 2 years. And then if you're coming back, you can start to continue payback by yourself. However, if you decide to stay there for long term, then they will pay you your school loan until every single dollar is paid off. So you can choose career radiologist, or you can stay home and read the CT scans from the other hospitals, or maybe you can take the time off to visit the hospital like Mitchell did it in Kenya. Thank you very much for your listening.
Thank you. Thank you so much, Dr. Hong, for sharing that experience. And, you know, I think you made just a really important point in regards to us providing what, and passing on, you know, what we've had the privilege to experience in education in this country, and pass it on to others with the limited resources and opportunities. Also, at this point, I want to remind everybody that the code for this session is perfusion, and please enter that into your post-survey link on the main expo page. So you can win an Oculus Quest 2. I don't know what that is, but I think it must be pretty hot amongst you young people. So without further ado, I'm going to introduce Dr. Jennifer Nicholas, who is a pediatric radiologist at the University Hospitals of Cleveland. She's the division chief of pediatric radiology and vice chair of education. Jennifer has worked, wow, I was amazed at all these countries, Jennifer: Honduras, Nicaragua, Mexico, Rwanda, and you have this great interest in integrating technology into medical education. So excited to hear about all that, and I'll hand it over to you.
Well, thank you, Susan. And that was actually a really great segue, because my next big project is trying to take the Oculus glasses and make a virtual reality for radiology training, especially with pediatric radiology, which will have some global, I think, potential as well. So we'll see. So whoever wins the Oculus glasses, reach out. We can get started on the project. So thank you for that nice introduction. Let me see if I can get my slides to advance. Okay. So my journey to medical school and radiology was definitely circuitous. I was 30 when I started medical school. And I spent my 20s really studying languages and teaching bilingual elementary school and Spanish in a lot of different capacities. And I actually have a degree in Spanish linguistics from Boulder, Colorado Boulder, as well as a degree through the School of Public Health at UNC. It's technically a Master of Healthcare Administration, but it has the MPH kind of embedded in that. So I'm also board certified in public health. And as Dr. Palacios mentioned, I have traveled to many different countries. The first place I went was to Honduras, and that was in a primary care clinic. When I was in medical school, I was at Duke, and they have a year where you do research, which I extended to 2 years with my kind of detour over to the School of Public Health down Tobacco Road. And that to me was a really well-structured, very meaningful experience. It was a semester-long course that was put together by one of the pediatric infectious disease doctors. It was very thoughtful. We learned the history of Honduras. We really worked on getting our clinical skills up to par. And then when I came to Northwestern for residency, I worked with the NUA group and went in 2005 to Nicaragua. That trip actually was really where I transitioned from doing primary care to doing more radiology focused. At that point, I was a second-year radiology resident. So I didn't really know much radiology myself, but there was an ultrasound machine that had been donated to the clinic through which our primary care experience was facilitated. And that was called Casa Materna. So not surprising based on the name that was a house that took care of pregnant women. And there was this really outdated, not really outdated, but really old ultrasound machine that had been donated. And I'm sure the people who donated it spent a lot of money to get it to Nicaragua, with one transducer that was really about the size of those shells that you can get on the beach. Kind of hard to even hold it in your hand. But it had been donated and there really wasn't any kind of transition plan. No one had spent much time showing them how to use it, and hadn't really done any training. So at the end of one of our clinics, one of the pediatricians pulled me aside and showed me this ultrasound machine. And she said, would you be able to teach me how to use this? And I was totally forthright at that point. And I said, well, I'm not sure I'm the right person to do it. I'm just in my first year of radiology or second year of radiology residency, but I can go back to Chicago and see if I can find someone. And I found one of my attendings who was actually, we had a relationship with Evanston Hospital at that time, and she was ultrasound trained. And we went down to Nicaragua the following year to work and help them optimize the use of that ultrasound machine. That project got the attention of a philanthropist in Chicago whose name will she'll remain unnamed for now. She's the namesake of the Children's Hospital there. She read about that project and reached out to me to see if I could help introduce ultrasound to her clinic in Kenya. And that started a 5-year relationship that I had with that clinic and the physicians there, and helping to train them in ultrasound, procure the machine. And then we did a lot of kind of teleradiology back and forth and helping them to get up to speed. That clinic closed in 2012, kind of unexpectedly. And then somehow Haiti appeared. Now I have a degree in Spanish. I studied a little bit of French, but really not enough to I think, be considered fluent. But ended up going down to radiology with the American College of to Haiti with the American College of Radiology in 2013. And then I've kind of been going back ever since. Now, the last time I've been was in 2018. That basically turned into helping to set up the infrastructure for their residency, including a couple of grants that I was lucky enough to get that helped us do a tablet curriculum where they could actually learn, the residents could take cases from the US that they weren't able to have through their residency. In 2016, I went to Rwanda, and in 2017, I went to Ecuador. I could add to this also, I've since been to Mexico City and Nigeria as an international visiting professor. I think one of the biggest things to keep in mind is that radiology is really practiced differently throughout the world. And as Dr. Hong mentioned, there they didn't have, they didn't have interventional radiology in Ethiopia when he went. And as Mitchell, Dr. Parag mentioned, there was really a lot of gain, a lot of ground that they could gain by kind of building the radiology infrastructure. If you think around the world, a lot of places, a lot of these studies are read by general clinicians. So it's important kind of when you think about global radiology that you're going to be partnering a lot of times with clinicians to help to build that infrastructure, at least initially. So when I first went to Haiti, there were 19 radiologists for a country of 11 million people. So they started a residency in a place that was already really short-staffed, and we were able to provide some of that attending support kind of remotely. There really are a lot of human resource limitations. There's lack of equipment, lack of supply, and there's inconsistent electricity and running water. Now, we take for granted that digital radiology is everywhere, but it's not. And in a lot of places in the world, there's still conventional X-ray, which is sometimes called analog, and that involves film, developer, running water, having to have a dark room, having to keep that film from being exposed to light in the transportation kind of supply chain. So that's kind of, there are a lot of places where you're still doing film, and in Kenya, we actually did do film radiography. Now, I'm lucky that my mom is an X-ray tech, and I did some photography back in the day when you actually had to develop the film yourself. So I have this kind of, special skill set. And at the time that I did my my thesis in medical school, I still had to physically copy all of those, the images that we were using for the study. There's also kind of this interim step between radiography and, analog and digital. And that was when we came up with this idea of X-raying a cassette that then could be uploaded into a digital system. So there's kind of all these different variations on the theme, and it's really important as you're going through radiology, understanding what is the infrastructure. This is just a reminder of what you can encounter. Okay, and I just wanted that to be kind of a general reminder that, when you are doing manual film processing, there are a lot of things in the supply chain and the process that really can be impeded. You can see it's also really important that these, facilities or these systems be maintained. So it's really a lot more difficult to get radiographs globally and in some of these settings than it should be. And I'll wrap things up here in a minute. This is actually my mother taking an X-ray in Haiti. So we went down to a children's hospital in Haiti, which is sponsored by the Catholic Church, St. Damien Pediatric Hospital. And what was happening here is this little girl had a retropharyngeal abscess. She had inflamed tonsils and ended up with a retropharyngeal abscess. And they wanted to get a nice lateral of the soft tissues of the neck. But the radiographers, the X-ray techs there, by no fault of their own, hadn't really been trained on how to use this machine as well as they could, or how to position pediatric patients. And so when they did their AP, they had just the patient look directly to the camera. And when they did the lateral, they just had the baby turn her head. So they basically had a side view of the head, but the neck was still in AP. So one of the first things that we were able to do when we got there is show them how to use their machine to do a true cross-table lateral. And that cross-table lateral view of the neck did show real thickening of her retropharyngeal soft tissues that resulted in, it was actually about 15 cc's of pus that they were able to take out when she was transferred to the hospital. So that really was, something that you kind of take for granted, is also having techs that really, know how to perform the right exams. Another thing to keep in mind is that even when you have digital systems, They have to be in, areas that are cool, or you can have things kind of burn out. And then there's also just kind of how do you keep the systems organized, right? Things that we just took for granted. This was the file room in 2010, that clinic in Kenya that I talked about. And actually their filing system was just put the radiograph when it's done on the top of the pile for that month. So it wasn't organized alphabetically by patient name. It wasn't organized by the medical record number. It was organized by the date of the study. So thankfully there was kind of this anachronistic electronic medical record. So I was able to dig through these, figure out the date of the study, and then find the studies. I think we probably need to stop for Q&A. That's just kind of a brief introduction, but I will stop sharing my screen and we'll go to the question and answer.
Thank you so much, Jennifer. Really amazing. And like I said, I definitely dated myself with that Oculus thing, but I remember the days where I actually, they did like the manual wet stuff with the films anyways, long time ago.
Yeah. That's okay. I guess the take home from all of it is learn as much as you can about how to scan, how to process film, how to take images, as many of the skills of radiology and even radiography and sonography that you can acquire along the way, the more useful you'll be. So that's just my take home.
Yeah. It's really being creative with what you have. We do have a question from a medical student, yay. And the question is, I pose this to the panel, when talking about these outreach efforts that you've also nicely presented, what specific factors do we need to keep in mind to ensure sustainability? So it's not just like a one-off. So chime in.
I mean, I think education is huge here. I think just training on-site techs is the number one thing. They have to understand protocols, how to do exams correctly. Just like Dr. Nicholas was saying, I mean, the example with the APN lateral neck radiograph, I mean, that makes such a clinical difference. So I think technologist training is a major factor in providing sustainability, because if we can ensure that these exams are done properly and consistently, then the techs who know how to do them can then teach younger techs to do them. And that's the biggest part of establishing a cycle.
Thank you. Another question, and this is a great one. The various radiology programs, is there a program that allows radiology residents to rotate abroad, is one question. I don't know that we have that at Northwestern, but and I don't know if there is at other institutions. It sounds like a great idea to me. It would be really a valuable rotation.
Yeah, not that I don't know for sure. Reddit is more of a volunteering organization, so it wouldn't be a formal organized rotation. That would probably have to be something that would be coordinated on an institution basis with your own institution, setting something up and coordinating with another place in a different country. If they have an established residency program there, that they may allow you to rotate there. I don't know if you guys know of anything.
Hey, so go ahead. It was Dr. Hong. Go ahead, Dr. Hong.
I think American College of Radiology is encouraging the residents to visit the mission hospital. I think they support a partial financial. Otherwise, you have to depend on the program directors, whether you can take 1 month or so as an elective rotation.
Great.
There are some programs like Penn, because of the relationship. There's the chief of pediatric radiology is Ethiopian. So Penn and CHOP, which is short for Children's Hospital of Philadelphia, have a pretty well established relationship with Ethiopia. Whether that translates into resident experiences, I can't speak to that definitively. But if you look at programs where they have these outreach programs, there's a greater likelihood that you would be eligible. There is unfortunately a lot of risk associated with residents traveling. And it depends on how risk averse the given institution is. So those are good questions to ask during your interview.
Thank you. And I think just maybe in the last minute, is there any prep that's involved for students and residents to go abroad and take advantage of these opportunities?
There are a lot of curricula that have been developed to kind of get you ready for the experience of functioning in a medical system abroad, and kind of the some of the stress that you'll have between what you would like to accomplish and what you're able to accomplish. And those are kind of just, you know, out there, kind of universally available, not necessarily through radiology. So on the personal level, I think for your first global health experience, if it's your first one, those are valuable. But as a radiology resident, as I said, as much hands-on as you can have, as many of the skills you can have, even how to use a CT scanner, how to post-process images. You need to be the doer and get your sleeves rolled up.
Great. Okay, well, I think that should wrap it up. Thank you so much, everybody. Thank you for attending. Remember the code for the session, perfusion. Have a great day, all.
Hey, thanks
Thank
very
you.
much.
Thanks,
Bye-bye.
guys.
Bye-bye.
You.